Warning. You are responsible for all content in your textbook from cover to cover. You have all the resources you need. Now go and win. Chapter 2. EMS Systems. There are several components that make up an EMS system. EMS is a comprehensive network involving personnel, equipment, resources established to deliver aid and emergency medical care to the community. So we have two separate areas that we want to talk about there. We want to talk about the out-of-hospital components of the system and the in-hospital components. Starting off, we'll talk about the out-of-hospital components. Members of the community that are trained in first aid and CPR. So we want to include them because initial recognition is one of the most important things with injury and illness prevention. The communication system, the dispatchers, the trunking systems, the ability for the bystander, whoever witnessed the event, to be able to communicate with the 911 system. They will initiate the EMS providers, including paramedics. Now, of course, this will vary depending from system to system, but for the most part, this is how the paramedics get involved. Fire and rescue and hazardous materials services typically get dispatched with the EMS services. Law enforcement, they are also dispatched alongside the EMS and fire resources. Public utilities such as power companies, any gas companies, anything to where more damage to property and life can be prevented, and also resource centers such as the Red Cross during flood situations, fires, anything of that nature to where people are going to be displaced out of their homes. In-hospital components. Here we're talking about emergency nurses, physicians, advanced practice providers such as nurse practitioners, physician's assistants, emergency and specialty physicians. At Northeast Georgia and Region 2, we have access to specialized trauma surgeons and cardiologists at the ready. Ancillary services, social workers, mental health providers, rehabilitation services, so on and so forth. And weaknesses in any one of these components will diminish the overall quality of patient care and patient outcomes. Now I want to skip to a brief overview of what we are about to talk about, because this is going to be a ton of information about history, historical events that have shaped EMS as we know it today. But yeah, it could potentially be kind of dry, boring. However, if you need to pause the video and look back at the big stuff that I want you to take away, these next slides with the highlighted material are going to be the big ones. You do get tested over this type of stuff at National Registry. So the onset of EMS and bringing medicine to the field happened much earlier than this, but the first formalized, notated historical documentation of 1797, Napoleon's chief physician implements a pre-hospital system designed to triage and transport the injured from the field to aid stations. Then we'll flash forward pretty fast to 1960. Cardiopulmonary resuscitation is shown to be it's shown to be very effective, and it's important that bystanders know how to do it because, as we know now, it saves lives. 1966, this is one of the big things that Registry will always test you on. The National Academy of Sciences National Research Council publishes The Accidental Death and Disability, the Neglected Disease of Modern Society, also known as the White Paper. And we'll talk about that here in a little bit. 1970, the National Registry of EMTs is founded. Notice emergency down there at 1970, but I don't think they're going to ask you about that at Registry. 1973, the Emergency Medical Services Systems Act provides additional federal guidelines and funding for the development of regional EMS systems. The law establishes 15 components of EMS systems. We will talk about those. 1981, the Omnibus Budget Reconciliation Act consolidates EMS funding into state preventative health and health services block grants. This eliminates funding under the EMS Services Systems Act. Pre-hospital trauma life support is developed in 1981 as well. This is derived from ATLS, which is Advanced Trauma Life Support. You will be going through PHTLS in your course, which, as I just said, is it's not necessarily watered down, but it's an EMS and nurse provider level form of advanced trauma life support. It is written by physicians who are in trauma theater in the military, SOCOM, things of that nature. So it's pretty well founded and well supported. In 1985, National Research Council published Injury in America, a continuing public health problem. This describes the deficiencies and the progression of addressing the problem of accidental death and disability. So kind of this is an update and a sequel to the white paper. In 1988, the National Highway Traffic Safety Administration initiates the statewide EMS technical assessment program based on 10 key components of EMS systems, and we will address each of those. In 2003, Health Insurance Portability and Accountability Act, so HIPAA. This is the big thing. You know, most of the people in this program are working somewhere at this time. Anytime you transport somebody, what do you have, or get a refusal? One of the forms you have to get them to sign is a HIPAA form. In 2003, this was in place. It strictly regulates the flow of confidential information. In 2006, the National Highway Traffic Safety Administration establishes Emergency Medical Services Agenda for the Future to guide the development of EMS in the United States in the 21st century. So again, we're going to talk about more than that, but these are the pretty big ones. These are the ones that these are the pretty big highlights if you wanted to say, okay, what do you really want me to take away from this? All right. So let's move on to history of EMS. So early development. EMS developed from traditional and scientific beliefs of multiple cultures, just like anything else. Most significant advances in EMS occurred during the last 50 years, however, and this is as we've become more proficient in scientific method and research, and we understand research a lot better. Also, we have larger sample sizes to pull from, and technology is advanced in a way to where a lot of our research is a lot more solid. During ancient times, well, we do have evidence that emergency medicine has a very long history. Now, this is just emergency medicine in general. This is not necessarily pre-hospital emergency medicine. Scribes in Mesopotamia, approximately 4,000 to 5,000 years ago, inscribed clay tablets with some of the earliest medical records. In 1862, Egyptologist Edwin Smith purchased papyrus scroll dating back to 1500 BC. Contains 48 medical case histories with data arranged in a head-to-toe order of severity. So it kind of goes to tell you that people have been working on medicine for a long time, far beyond what we can even imagine. King Hammurabi of the Babylon commissioned a large painting of 282 case laws known today as the Code of Hammurabi. One section of the Code of Hammurabi was devoted to the regulation of medical fees and penalties. Interesting fact. Okay. Around 900, Anglo-Saxons used a hammock suspended across a horse-drawn wagon for transport. So I guess you can call this the first boo-boo wagon transport ambulance. Let's talk about the Napoleonic Wars, because we were talking about how Napoleon utilized this to save a lot of his soldiers' lives. Napoleon directed Dominique-Jean Larrey, his chief surgeon, to use and evacuate wounded in wars between Napoleon's French Empire and the other European countries. This proved to be advantageous in as far as saving lives and preventing further deaths. The United States in the 19th century, we developed ambulances in the U.S., and this typically, again, this occurred in war prior to occurring in the civilian world. The first civilian ambulance to be noted was in 1860 in Cincinnati. Bellevue Hospital in Manhattan in 1869 began to operate an ambulance service as well. All right, as we move on to the 20th century, from World War I to World War II, we'll talk about some variances in between there. From World War I, we had a very high mortality rate associated with the evacuation time of 18 hours from theater. The system of transportation to increasing echelons was created, and so we also put physician interns on ambulances. So this made the likelihood of a soldier or a wounded warrior to survive a lot higher. In 1926, Phoenix Fire Department's inhalator service was initiated, and in 1928, the first rescue squad, the Roanoke Life Saving Crew, was started. In 1929, the period of the Great Depression, there were very few changes in civilian ambulance services. Obviously, it takes money to do this. So, moving on to the Korean War, this is where we really started to see a lot of increase in lives being saved in theater. A lot of the soldiers actually having better outcomes. So this is around the 1950s. In the Korean War, helicopters moved injured to mobile army surgical hospitals, and I'm sure everybody has heard of the show MASH. If you haven't, you really had a bad childhood, I guess. I can't say that these days, but MASH was great. Watch it. I'll just say that. But this did set the stage for trauma systems in the United States. So this kind of set up a triage system. This set up the ability for pre-hospital care to be initiated, and then rapid care to be initiated at a higher echelon of care closer to the actual war. In 1956, mouth-to-mouth resuscitation was brought to the forefront. This was brought by Peter Safar and James Elam. They pioneered the first technical mouth-to-mouth resuscitation. In 1959, the first portable defibrillator was used at Johns Hopkins Hospital. In the 1960s, so let's jump to 1960. Yes, we do have the implementation of CPR, so that's very important. That really set the standard for what we're doing today. But one of the big things to remember, again, in 1966, the accidental death and disability, the neglected disease in modern society, also known as the White Paper. It spelled out deficiencies in pre-hospital emergency care, and it also suggested guidelines for development of EMS systems, training of pre-hospital emergency medical providers, and upgrading ambulances and their equipment. This identified multiple problems. So the big takeaway from this paper was that we see the evidence of saving lives in a wartime theater. Why aren't we applying that to stateside, to the public life? So, and also it was addressing the preventable trauma deaths that were occurring, and they were saying that this is completely preventable. All we have to do is just set up a system. All right. In 1970, so we'll talk about the 70s really quick. 1970, the National Registry of Emergency Medical Technicians was established, and they created the most feared and revered test known to man, but that wasn't put in place until later. Anyhow, in 1972, the television show Emergency was aired. The biggest reason that this is important, they didn't really come up with any great protocols or change medicine, but they did introduce us to the public. They introduced the profession of EMS providers, of pre-hospital clinicians, to the mainstream public. Now, just like all the modern shows, well, I will say Emergency was probably a little more realistic. However, the modern shows that everybody watches on all the various networks can be quite outlandish. A lot of the movies make us look like superheroes and very unrealistic, but they have to keep your attention somehow. So, in 1973, Congress passed the Emergency Medical Services Systems Act. So we'll move on down. We did talk about that, which addresses 15 components of EMS systems. So one of the first components was manpower. The next was training, communications, transportation, emergency facilities, critical care units, public safety agencies, consumer participation, access to care, and patient transfer. Also, the standardized record keeping, public information and education, system review and evaluation, disaster management plans, and mutual aid agreements. So you can see that this really that the Emergency Medical Systems, or excuse me, the Emergency Medical Services Systems Act was crucial in developing a system to at least have a starting point. Now, we've moved forward very, very much so. However, in some areas we have not. In some rural areas of the country, we're still struggling to implement some of these, or at least make them efficient. So move on down. In 1988, the NHTSA, that's the National Highway Traffic and Safety Administration. They implemented the 10 system elements that would be required for EMS services. Those are as follows. We have regulation and policy, resources management, human resources and training, transportation, facilities, communications, trauma systems, public information and education, medical direction, which is very important, and evaluation. Okay, so we'll move on to the 80s now. Great era for music and movies. Some of the best movies that will ever be made, and I hope to goodness that they don't try to remake them. Yeah, if anybody messes with Back to the Future, you gotta answer to me. Sorry, don't sue me for copyright privileges. 1980s, helicopter air ambulances were developed. Literally, we're copying the model that's been utilized since the Korean War, but we're just making it. We're making it public. We're making it private. In 1996, this is huge. This is a very important thing, almost just as big as the white paper. The National Highway Traffic Safety Administration published the EMS agenda for the future. So this is what pushed us. This is what has pushed us a little closer to where we are today, mainly on the integration of health services. So this took all of the different individual components of the EMS system and made them operate as a team. They're integrated now. EMS research. This is huge. We cannot move forward without validated, comprehensive data, and this was started following the 1996 EMS agenda for the future. Legislation and regulation. We started to have representation for ourselves in order to move our profession forward. We're still working on that, and we'll talk about professional organizations later in this lecture. System finance. How do you pay for a system that typically just costs money? We don't really generate revenue. We don't really generate money like the police services do, like the sheriff's departments. So how do you regulate the finances? Human resources, obviously, anywhere where there's an employee, we have to have some type of checks and balances with human resources. Medical direction, they give us the ability to do what we do. Even in this EMS program, you have a medical director who gives you the ability to operate in clinical. They give us the ability to write the curriculum. Without a medical director, none of what we do is possible. We are literally an extension of that physician. Education systems. So let's talk about that. We have EMS education systems, which are still in gross need of accountability and building up, but we also have public education systems. We have public education, which is definitely our job. A lot of people don't like to do it. You just want to run your calls, do your reports, and go home. However, if you can prevent the call from happening, the patient, it's all about the patient. You come to work every day for the patient. So public education is how we make patients' lives better by preventing the call from occurring. Public access. So in certain parts of the state of Georgia, they don't have the access to EMS systems or hospital care that you may have in a more populated area. Communication systems. Some are more sophisticated than others. Some are fancy and digitized and clear as a bell. It sounds like you're having a conversation with a dispatcher. However, some are still very archaic. You can tap into them, listen to them on your scanner while you're eating your mac and cheese, and just listen to what's going on at Bobby Joe Sue's farm down the street. Clinical care. Some areas still do not have comprehensive clinical care. However, we're working on that. Information systems, so data gathering, also the ability to collect this information to establish research, and also evaluation. What parameters are put in place in order for us to evaluate how well our EMS system is doing? It's incredibly important. So let's talk about the 21st century. Obviously, 9/11 occurred, and it really changed the game, not only for EMS, but for everyone. The Department of Homeland Security was developed in the 21st century, which obviously coordinates agencies responsible for protecting the country. In some long way, form, or fashion, any type of public safety organization is going to eventually tie back to the Department of Homeland Security. You have FEMA, you have GEMA. GEMA is the Georgia Emergency Management Association. Some departments and services fall under them. However, some departments and services fall under the Board of Health. So one thing that we can take away from 9/11 for sure is the National Incident Management System was formalized. It will prepare the country for terrorist attacks and other threats. This is implemented in any system, any large-scale event, any call. You use the National Incident Management System. A house fire, a mass casualty wreck, a mass casualty active shooter incident. The incident command system must be set in place, because without sound communication, without organization, it is literally chaos and nothing can get done. So that is why it was very imperative for that to be formalized and to actually be set into place. Still talking about the 21st century, let's talk about the Emergency Medical Services at the Crossroads, which was published in 2006. Okay. It identified some issues that we had following Hurricane Katrina. So although we had the National Incident Management System implemented and supposed to be working at this point, we still had very insufficient coordination. We had coordination of transport within regions that were very limited. So we had patients, but we had nowhere to take them, or those places that we were taking them were so oversaturated that we didn't really know what to do with these patients, and poor outcomes occurred because of it. We didn't really think about implementing other flight services from bordering states. Disparities in response times. So how long did it actually take the people to get there? Uncertain in the quality of care. So there's nothing to document whether or not we are doing our job. That's terrible. That's not a good thing. Of course, we hope that there wouldn't be any doubt. However, objectivity is one of the most important things that you can have in your career. And as long as you do a good job, you shouldn't be afraid of anything. Lack of readiness for disasters, so preparation for emergency management associations, for EMS services, fire departments, public safety organizations, and then divided professional identities. Services not working with others or not working well with others. Services not having tabletop discussions to discuss what are we going to do in the situation where a mass casualty incident or whenever the mutual aid agreement is actually going to have to go into place here. And then also, this is one of the big things that I want you all to take away from the next 12 months of your time here. Limited evidence-based research. That is the only way we can move forward, is evidence-based research. Let's get rid of the anecdotal tradition and anecdotal, this is what I was taught and this is what my trainer was taught, so by George, this is what I'm going to do. No. Base what you do off of evidence. It may change. You may be doing something different in the next 2 years because they found that another medication is more advantageous. For example, in the case of a STEMI in Region 2, as long as it is confirmed, we're bypassing the ER, we're going to the cath lab, we're giving heparin, we were giving Plavix. However, now we are giving Brilinta. So, and this was a change that was made over the course of 4 to 5 years. So this is something that you have to be willing to have evidence-based research evolve how you practice. All right, in 2006, the National Report Card on the State of Emergency Medicine, evaluating the environment of emergency care systems state by state. So this was this was something very important in order to determine, where do we stand as a country? Where do we stand nationally in reference to our ability to take care of large-scale incidents? Or where do we stand nationally in comparison to each other? How does the state of Georgia compare with the state of Washington? How does Hall County, Georgia, or Gwinnett County, Georgia, or let's use a more rural service like Dawson County, Georgia, Habersham County, Georgia, how do we compare to King County, Washington? Of course, there are going to be several variables and variances that cannot be controlled: population density, income levels, things of that nature. However, we can still use a baseline and compare and look at where we can go from here. So in reference to helicopter EMS, just to show you the importance of, or not the importance, but the impact that a lot of these large scale incidents has had on helicopter EMS or helicopter ambulance services. In 2001, we tripled the national medical helicopter fleet from 300 to 900. 2008, unfortunately, there was a record number of helicopter air ambulance crashes with fatalities, and which resulted in the NTSB hearings. And that kind of changed the way that a lot of the flight services are doing what they're doing. Let's take a short break. Look for part 2 of lesson 2.